Hi everyone, welcome to this presentation on design thinking for low resource contexts. My name is Nabeela Laher. Before we start, I would like to tell you a little bit more about myself. I'm an NDT trained pediatric physiotherapist. I've had quite a diverse career, and part of it was in the private sector, working in my own private practice, as well as in a well-resourced environment for low-functioning children called the Apricot Tree Center for Stimulation and Development. After doing my NDT training, I've also spent a big part of my career within the non-profit sector, delivering services in a low-resource context. And being in this kind of context stimulated an interest in something called social entrepreneurship, which is essentially about creating innovative, sustainable, and impactful models that help more people to access better lives. As part of the social entrepreneurship program that I did at Gordon Institute of Business Science, there was an action learning project that we had to do through the year, where we had to research and design a solution for a problem that we were facing within our organizations. And so this is what this presentation will be about. And as a side, since this journey, I'm now a consultant and director. I run a consulting firm called Form Development Consulting, where I bring concepts of social entrepreneurship to others. And then also we run an advocacy platform called Rehab for All South Africa. And Rehab for All South Africa is about stimulating innovation and development around people with disabilities in South Africa. We particularly promote wider access to rehabilitation services, innovative and sustainable models of care, and wider collaboration, not just between people within the healthcare sector, but also between rehabilitation professionals and those outside of it. This project will be a kind of example of this kind of collaboration, and I hope that you are going to find it useful. So the title of the Action Learning Project was Using Design Thinking to Enhance Outcomes and Sustainability of Wheelchair Service Delivery at a particular organization, whose name I will withhold for this presentation. And to give you some background, this is a non-profit organization based here in Gauteng. It has been around quite some time, and they provide full-time residential care to 300 people with moderate to severe level disabilities. This organization exists as a source of social support to families, and most of them are from low-income backgrounds and do not pay for services. The organization funds itself through government sources, about 40%, and through raising donations and corporate and private donations, and also earning some of its own money. Like many nonprofit organizations today, they are struggling for sustainability. Since 2007, the economy has changed a lot, and nonprofit organizations themselves find a need to transform their models and become more self-sustaining and less reliant on donor funding, as well as more innovative and efficient. Now, during my time working there, I was a physiotherapist for 7 years. And most of the time, I was a single part-time physiotherapist. There was no occupational therapist and speech therapist for most of the time there. And I ran several interventions within this population group. One of them was specialized supportive wheelchair seating. We had a huge amount of very severe cerebral palsy, level 4 and level 5. And this was one of the most important parts of my work there, because for this population, seating is really important, not just for learning, development, but also for feeding and safety, and also, for their growth and making sure that they do not grow into deformity. For those who do not work a lot in seating, just an idea of the kinds of chairs you get in South Africa. The middle chair is a chair called Madiba Buggy, which is allocated by the government and retails at about 15,000 Rand. And then on the far right, you've got the many kinds of chairs available in the private sector, which are a lot more expensive, but a lot more adaptable, and also sometimes require technical expertise to maintain and use. Now, the challenges that I faced within this organization is that being a sole therapist within an organization that has a fundamentally different mission, There was no real formal system through which to develop these services. In a government setting, you would have an entire rehabilitation management system who are budgeting, who are planning for your services. In this kind of case, you often feel like you are competing for resources and there's not enough focus on developing services like these. There's also limited organizational knowledge because organizations are generally managed by non-rehabilitation professionals. And they also have a lot of things to keep their eyes on. And so I found that, it was quite difficult to get the support that I needed to do what I needed to do. Often as an NDT therapist, I found that my clinical interventions were meaningless because the seating that I would set up would be lost very easily. Staff were unable to maintain it because they were overworked or too busy. And so I recognized just very, very early on that for this system to change, I needed the organization to recognize the need for the service and support it on a much larger level. Now, what is design thinking? Design thinking essentially is a concept that fills the gap between research and practice. You look at each situation as unique and develop a solution on it based on research, which is usually looking outside of the actual system or context or setting that you are in. You then take this research and use it to create a base for your services, as well as a foundation for continuous learning and development. For this project in wheelchair seating, I did a literature review where I looked at health systems. I looked at wheelchair service delivery guidelines, especially from the World Health Organization, and I looked at research in the South African context. I wanted to collect baseline data on to establish the actual level of need within the organization. I ran qualitative interviews, and these interviews were of people who had a lot of experience in this field, either as therapists or technical providers in the government, nonprofit, and private sector. And then I also did a focus group of the district rehabilitation team, which was a team by government that on the potential in the area, in the community, to establish their resources and challenges. From here, I created a solution and an action plan for the organization to follow. The most interesting thing out of the research was that majority of wheelchair users were young children and teenagers with cerebral palsy, and this means that they were at risk of developing postural deformities. Another interesting thing that came out of the research was that the majority of the owners of wheelchairs were owned by the organization itself. They had procured it some time back, a long time ago, through donations, and very few residents actually accessed wheelchairs from the government, which they were entitled to, and there were many, many factors that were contributing to this. The qualitative research, I found that there was limited integration within service delivery models between clinical professionals and technical professionals as prescribed by the World Health Organization. There's a high risk in wheelchair procurement. It's really expensive. Ordering the wrong thing and importing the wrong thing often meant that you spent a lot of money on something that cannot be returned. There's big discrepancies across environments, across between public and private, between access to wheelchairs. And skills development is a challenge in many settings. Departments and schools do not have the funds to skill their therapists, specifically with training in cerebral palsy, for example. And then technical support, ongoing follow-up, maintenance, repair is absent or happens very minimally throughout the system, and there's many reasons for this. For example, medical aids do not cover it, and then government has very little capacity to repair, follow-up, and maintenance and maintain wheelchair. The positive that came out of the research was that when interviewing the district team, I found that there were many resources actually available there, financial resources for wheelchairs. And to this point, this team or this community-based team had just not sufficiently integrated with the organization. And there were many reasons contributing to this, but this was definitely an area that could have moved forward. This was the service delivery model that was created. And basically, the organization would, as would have a tiered service delivery model as recommended by World Health Organization. In a community-based setting, this is always recommended so that you can focus your clinical skills on top tiers that need it the most and train people on the ground to do lower skill level wheelchair prescription. They would access the resource from the district health system and then also from private service providers as needed. And they would have to use a variety of strategies for this, including donor support, tapping into the family resources themselves if they have, supporting nonprofits and medical aids. They would also need to get donor support and allocate it specifically to ongoing follow-up maintenance and repairs, because there's no point in getting an expensive wheelchair if you cannot maintain use of it. And then, you'll also find in this diagram, there's a skilled therapist, and the skilled therapist is there really as a controlling system to assess the kids, to screen them, and to make sure that they are getting the right thing and they are being managed in the right way. Now, none of this would be possible without absolute, complete buy-in and support. And so the framework that this model would be located in, it has to happen within not just therapy department, but has to be supported at all levels of the organization. And so we had to create an action plan, and the action plan was a 6-month action plan. And it describes specific roles of various people in the organization and their tasks and the deadlines that they would have to support the development of the service. Within therapy, what we had to do ourselves was to strengthen our administration systems around the seating services and also embark on a screening process of residents, classify them. And in the care and nursing part of the organization, need to strengthen their protocols in terms of how they trained new care workers, how they maintained wheelchairs, how they monitored use of wheelchairs, etc., and how they referred and who they referred to. And then the management of the organization itself had to become involved with engaging with stakeholders, various stakeholders, and also fundraising and development. And it was suggested that they allocate a certain part of their funds towards this and develop a specific fund to support the service. So in conclusion, what I'd like to say is that I found through this project and through my work at this organization that there is an incredible potential to develop services in low resource settings. Oftentimes we find ourselves in a situation and we think this is all that's possible, this is how it's always been. In this organization itself, they were really struggling financially throughout all this time, but our therapy services just continued to grow and grow. And this shows really the value of, looking at the big picture, thinking outside the box, applying principles of design thinking, and engaging every single person that you need to. You have to, as a therapist, be an advocate for your services when working in a setting like this. You've got to be prepared to work at every single level of the organization, understand where the change needs to happen, how the organization themselves can support it sustainably, demonstrate and prove the value of your services in case you have to make a business case for it. And in this case, I think I've shown on some level how to do that. I really hope that this presentation has been helpful to you. I want to encourage you to follow our work at Rehab for All South Africa. We are on all social media platforms. We also have a newsletter which you can sign up for. And also, please feel free to come into contact with me. My email address is rehabforallsa@gmail.com. I'm really, really happy to engage with you on anything around these themes and concepts. Thank you very much.